So on to the Deauville score. So what is the Deauville score and how should we use it for our lymphoma patients? So the Deauville score was developed in 2009 at the first international workshop on interim PET scanning in lymphoma, and that occurred in Deauville, France, and that's how it got its name of the Deauville score. And this was to try and replace the previous International Harmonization Project criteria, also known as the IHP criteria, which were really initially developed for interpreting end-of-treatment PET. And in that criteria, basically negative was having less than blood pool or less than background. And there have been annual international workshops on PET in lymphoma since this initial one. Those have been ongoing since 2010. And I think they've been helpful to try and clarify things, but as you'll see in my conclusions, I think we still have a long ways to go to try and figure out how to best use this scale, or should we be doing something different. The Deauville score applies to, or we have only one scale for all lymphomas, so this sort of applies across the board, if you will. And it is a qualitative visual 5-point score and used to assess differing degrees of response at both mid-treatment and end of treatment, and compares the uptake in the tumor to normal structures like the blood pool and the liver. And the advantages over quantitative methods, which would be things like delta SUV, are that this visual score has less dependence on having a consistent method of acquisition or processing, meaning that the patient, if you're using quantitative evaluation, you have to be very careful about the patient having their PET scan exactly the same time after the injection, both pre-treatment, interim, and end of treatment. And that's very hard to do in a clinical setting when people are piled up in the waiting room of the PET and they've had the injection and then something happens and they're delayed, so it's longer, or they're in a hurry and it's shorter. So by doing the visual and comparing it to liver or blood pool that occurred at exactly the same time, you're less dependent on that. And also less dependent on sort of rigorous quality assurance of the equipment, which I think can be quite variable in different institutions. There does appear to be very high inter-observer agreement with this 5-point Deauville score in Hodgkin's, in DLBCL, and in follicular lymphoma, and there's multiple reports out there showing, again, very high inter-observer reliability and concurrence. And it's consistently has been incorporated into lymphoma clinical trials evaluating both interim and end-of-treatment PET. So that's the other good thing about having this Deauville score, is it's something that can be used across all trials, hopefully making it easier to evaluate those trials comparing one trial to another. So the criteria as developed in 2009 is a 5-point scale plus an X category. So 1 means no uptake. 2 means that you have uptake less than or equal to mediastinal blood pool. 3 means that you have uptake greater than mediastinal blood pool, but less than or equal to liver. 4 means the uptake is moderately higher than liver, and 5 is uptake markedly higher than liver and or new lesions. And then you can also designate the scan with an X, meaning there are new areas of uptake which are unlikely to be related to lymphoma. So you would still give it a score of 1 to 5 and then add an X if you think there are other things on the scan that are not likely to be lymphoma. And the problem with the initial 2009 publication is that there was no definition of moderately or markedly for 4 or 5. And so the question really was, the people who are missing from this are the patients who have a mildly increased uptake over liver. Is that a 3 or is that a 4? Because 3 says less than or equal to, and 4 says moderately higher. So there is some wiggle room there actually for the nuclear medicine radiologist in terms of that mild category. And I do think that most of the nuclear medicine radiologists were calling those 3s, quite honestly, if it was just slightly above liver. And so they re-looked at these in 2014 at the same time that the Deauville classification came out, and those are probably the two papers that everyone should take a look at if they're more interested or if they're interested in this topic, and those are the two references at the bottom of this slide that came out in the same issue of JCO. And the Chesson paper is actually the Lugano classification, and the Barrington paper is more of a drill down on the interpretation of the PET, describing these scores in more detail. So one thing they did in this 2014 update was try and be more quantitative, even though this is still a visual scale. And initially, I thought this would be quite helpful, but as with many of these things, this was developed kind of empirically, and so then when you try and start putting it to use, issues come up. So now in the sort of update, moderately defined as greater than the maximum SUV in a large region of normal liver. And I'll talk about that more in a minute. And markedly is now defined as uptake that is 2 to 3 times the maximum SUV in the liver. And I had a long conversation by email this morning when I found out that I was going to do this talk with the head of our nuclear medicine, Barry Siegel at WashU, to kind of get his opinion about trying to quantify these things and comparing them to the maximum SUV in the liver. And I put on this slide some of his words directly, which is the problems with this are that most commercial PET viewing systems don't have a reliable tool, that will segment the entire liver volume so that you can find the SUV max. So instead what they have to do is they have to draw a volume around the liver, either as a sphere or an ellipse, and then move it around until they find the pixel that is the maximum SUV. And he said that takes a lot of time, and most of them actually are not doing that. So even though these criteria are very clear about what you should do, even in an institution like ours, where they're very academic about these things, if you go back and look at many of our PET reports, they do not include the maximum SUV of the liver, but instead a mean SUV. And so I think it's very important to confirm that this added time is actually adding value to our ability to interpret the PET scans and how we use them in clinical practice and in clinical trials. And I also am concerned, and I'm going to show a couple of cases that I think this new quantification may change how patients are categorized, particularly in the 3, 4, and 5. And so if it changes things moving forward, then how do we interpret those numbers compared to our old numbers? And I'm concerned that there's going to be more patients who used to be called a Deauville 3, where you had that wiggle room where you could be slightly above liver and still be a 3, that are now going to be called 4s, and that the 5s now represent multiple scenarios, some of which I will argue in the patient I'm presenting actually could even be a 3 in the old category. But at least certainly might have been a 4. So a current 5 could represent a response, a patient who had an SUV max of 25, which I'll show you these slides, that had 25 initially, goes to 5, so that's a 79% decrease in the max SUV, but still the 5 is more than 2 times the liver, because the liver was 2.4 or 2.5, and so that's a 5. And then it could also represent a 5 could be a patient who had no response to treatment, and a 5 could be a patient who had progressive disease. So I think we need some work on the 5s to help us figure out sort of how to interpret those reports. And a point I'm going to make at the end, but I'll make now to sort of reiterate it, is very important that you look at these PETs yourself, or at least have a conversation with the nuclear medicine physician about these PETs, especially somebody who's called a 5, because you might read that and you say, 5, okay, we're done with that treatment, we're moving on. Whereas it really could be a patient who's had a very good response and you shouldn't be changing treatment. So this case is a 60-year-old gentleman who had a new diagnosis of transformed triple hit DLBCL, had bulky intra-abdominal disease. We started him on dose-adjusted EPOCH-R, and he had an interim PET following 2 cycles. The report is read as a Deauville score of 5. The maximum SUV of the tumor, so this is the patient I was describing, 24.5 to 5.1, with a 79% decrease, and the maximum SUV of the liver was 2. The only residual uptake on his entire scan was a 1.3 centimeter right inguinal lymph node that had an SUV of 5.1. And so these are the scans. The left is the pre-treatment, the right is post-cycle 2. The top is an axial view of his inguinal region, and then the bottom ones are where he had his bulkiest disease in the retroperitoneum. So you can see on the left, he had not bulky, but significant bilateral inguinal adenopathy, and he also had this very large retroperitoneal mass. And on the right, you can see that the bulky disease is completely gone. He has one very tiny left inguinal lymph node, 1.3 centimeters, with an SUV of 5. So that's a Lugano 5. So I would argue that that patient is going to do well, hopefully. But I mean, he has triple hit, so maybe he won't. But we actually, this is a very current case, just a patient I'm seeing now. So we decided to go on with his dose-adjusted EPOCH-R despite his Deauville score of 5, and that he is, I think, just getting cycle 6, so he'll have another PET in about a month, and we'll see how that looks. And so then the second patient is a 54-year-old woman who has recurrent follicular lymphoma, initially received bendamustine Rituxan for 6 cycles, achieved a CR back in 2010, had maintenance Rituxan every 3 months for 8 cycles going through early 2013, and then in October of 2016 had a recurrence in her nasopharynx, pleura, and breast. And she had a biopsy of both the breast and the nasopharynx that were consistent with follicular lymphoma grade 1-2. She was registered to a phase 1 clinical trial, which included Rituxan in combination with ALT-803, which is an IL-15 superagonist. And the treatment in that trial includes Rituxan plus ALT-803 weekly for 4 weeks. And then they have a 2-month break, and then they get 4 maintenance doses of the combination, 1 every 2 months. And the study is sort of exploring looking at PETs, so the patients have a PET right before their first cycle of maintenance, so that would be 2 months after their last dose of the 4 weeks of induction. And so on the the 8 weeks post-induction are the scans on the right, and on the left are her pre-treatment scans. The end of induction scan was called a Lugano or a Deauville 4, and she had an SUV decrease from 12.9 to 2.7. Her liver was 2.2. And so you can see on the left, she's got the breast lesion on the top, in the top picture, and she's got the pleural lesion on the bottom picture on the left, and then on the right, those same areas. And so, again, when you look at these, and again, I'm not looking at them, I'm looking at them on our clinical system, and I understand that the radiologists have a much more sensitive system for looking at these and sort of changing the view in terms of the intensity. But for the clinician looking at these, she looks like she's had a great response to me. And so, again, is 2.7 compared to 2.2, is that moderately increased above liver? I don't know, but on the new criteria, yes, because anything above the 2.2 is a 4. So just to kind of then move into how they're using this new definition of the 5-point score, or how we use the Deauville score to determine a patient's response and assign a response. So this is the Lugano classification that was published in 2014 by Dr. Chesson in JCO. And so there are really 4 categories now in terms of PET-based response. And I think we didn't really chat about this too much in the debate. Ann and I didn't, but I would bring up right now, I think this again is one of those areas that's going to cause a little bit of confusion moving forward, because, for instance, the BB-NEVO study that Ann presented, the multi-center study that's as in first relapse, gives the overall response rate according to the metabolic response, including partial metabolic responses, which are patients who have score 4 or 5 with reduced uptake compared to the baseline, but no quantification of reduced uptake. So if they have any change, is that 10%, 20%, 30%? What is a change in that uptake? And so it allows, the interpreter to say if there's been any decrease. If it went from 24 to 21, then that's a partial metabolic response. Whereas clinically, I think most of us would think, not so good. So anyway, the categories, the complete metabolic response are scores of 1, 2, and 3. Partial metabolic response is 4 and 5. You can be no metabolic response and be a 4 or 5, or progression and be a 4 or 5. So I think as we'll see on the next couple of slides, that's a little bit confusing. So in terms of the response, according to the Deauville score for 1 and 2 is definitely a complete metabolic response. In the publication, they say score 3 is probably also a complete metabolic response. And then they add this footnote that says, but in response-adapted trials exploring de-escalation, score 3 may be deemed inadequate response to avoid undertreatment. And I personally think that statement is too conservative, especially if we're using the 2014 definition, where uptake is anything greater than liver is a 4. So, and I would use the RAPID study and the CLGB 50904 to argue that 3 is a complete remission and that you shouldn't put the 3 in the category that's going to get additional treatment. So this was really asking the question in both of these studies about getting rid of radiation in patients who have early stage Hodgkin's that is non-bulky. And so in the RAPID study, the patients were defined as positive if they had a a Deauville score of 3 to 5, and negative if they had a Deauville score of 1 to 2. And then they were randomized to radiation or observation after 3 cycles of ABVD. And this shows the overall results, no change in survival, and there was a trend toward an improvement in the patients who received radiation. And 75% of the patients in this study were PET negative. What was interesting was in the supplement of this article, they showed us the PET positive patients, and as you can see that the PET positive patients had a 3-year PFS of 87%, and that 90 of those 145 patients had London-Deauville scores of 3. So I think initially when we saw this, we're like, oh, just radiate everyone who has a positive PET because look how great they do, 87%. But I think the problem is that many of those patients who were radiated, probably 90 of them, were probably already in remission. So I think it doesn't help us decide what to do with the 4s and 5s. And so then Dr. Strauss's study through CLGB 50604, again, same patient group. Now the definition of a positive PET is 4 and 5, and 1, 2, and 3 are negative. And patients got 4 cycles of ABVD instead of 3 cycles of ABVD. And so here you can see the PET negative patients on the top that they had a 3-year PFS of 92%. So they look exactly like the patients in RAPID who had Deauville scores of 1 and 2. So I think from this we can say that comparing RAPID and 506 and 50904, that the Deauville 3 score is negative, because when you put those patients with the 1s and 2s and you don't radiate them, they have the same outcome as when you only use the 1s and 2s. So then let's move on to the 4s and 5s, and I've already alluded to this about what the problem is with 4 and 5 in terms of having 3 different categories. Could be a partial metabolic response, could be a no response, could be progression, and what's my time? Am I over? Yeah, okay, well then I'm going to skip these pictures because, but I did want to just talk about the response for 4, 5 in terms of the partial metabolic response. So these are the statements right out of the paper that at the interim, if you have a 4 or 5, it suggests that you're responding to treatment if you have a partial metabolic response, but at the end of the treatment, it suggests residual metabolic disease. And I think that I had presented this from the 50303 study at ASH, which was the PET sub-study. So patients had a PET after 2 cycles, and they also had a PET at the end of treatment. And the red line is the patients who had a negative interim PET and on the left and on the right are the patients who had a negative end of treatment PET, and the blue lines are for patients who had an interim positive PET, meaning 4 or 5, and the right is the end of treatment 4 or 5. So I think we don't absolutely know a patient who has a 4 or 5 at the end of treatment. I think we were all pretty surprised to see this, that they might not have residual disease. So you need to be very careful about interpreting that. So in terms of how I use these Deauville scores in my practice, that with early stage non-bulky Hodgkin's or DLBCL, I do get interim PETs after cycle 2. If it's a score of 1 to 3, I give them 2 more cycles of chemo and no radiation. If they have a score of 4 or 5, I repeat the PET after cycle 4. If they're a 1 to 4 at that point, I go ahead with the radiation. If they're a 5, I actually consider a biopsy. If the biopsy is positive, I would actually not just give them radiation. I would give them alternative chemotherapy, perhaps even a stem cell transplant, and then radiation. If they advanced Hodgkin's or DLBCL, I also get interim PETs in those patients. Scores of 1 to 3, I just complete the 6 cycles of chemo. Scores of 4, I complete the 6 cycles and I repeat it. If it's negative at the end, we're done. If it's positive, then I try and get a biopsy, or I even repeat the scan 3 months later. If they have a 5 after cycle 2, I actually get another PET after cycle 4, because I think if they really are having no response, I don't want to give the entire 6 cycles of ABVD. If they have another 5 after 4, then we change treatment. I'm going to skip that. So just my final thoughts. Looking at scans yourself, which I already said, and interpreting those in the context of the clinical picture. Not all Deauville 5s are failures, may not need to alter the treatment plan. And certainly in patients where you're not sure what's going on, you should biopsy or repeat the scan in 3 months. Really, if the patient has refractory disease at the end of chemo, waiting 3 months is not going to change the outcome. So I wouldn't just forge ahead looking at those 50303 end of treatment PET. Some of those patients may do just fine. Thanks, and sorry I went over.